Hello there, it's Luke, and in this tutorial we're going to introduce the concept of a maladaptive neurohormonal response, by which we mean the mechanisms that your body normally uses to maintain your blood pressure and hence tissue perfusion actually work against your body, and this occurs in the context of a heart that is failing or something that's perhaps in what we refer to as cardiogenic shock. Now, there we go. We have previously talked about the relationship between cardiac output, which is the volume of blood that is ejected from the left ventricle every minute, and that's related to the stroke volume. So that's how much is ejected with each contraction, and the heart rate, which is beats per minute. And similarly, there's a relationship between the blood pressure, that cardiac output, and the systemic vascular resistance, which is the tone of the smooth muscle within the blood vessels, mainly the arterioles of the body, which combine to give you a good blood pressure. And we can combine those two relationships into this one here, which shows that your blood pressure may go up and down depending upon the stroke volume, the heart rate, and your systemic vascular resistance. And so when we're considering the compensatory mechanisms that help to maintain blood pressure and therefore tissue perfusion, we'll be discussing it in terms of these variables. So we're going to be considering all of this in the context of a failing heart, perhaps somebody with cardiogenic shock. And I think the best way to demonstrate that to you is to again go to this transthoracic echocardiogram, and we will orientate ourselves just now. So the bit I want you to focus on is this bit here I'm just pointing to with the cursor where it says LV, the left ventricle. And we can see the sort of septal wall here, the free wall here, and the sort of annulus where the mitral valve sits. And in a healthy heart, you would expect to see these sort of three structures coming together and squeezing out the blood within the left ventricle. So we've got a couple of images here. The one in the centre of your screen shows a healthy heart, and you can see those two walls and the annulus all moving towards one another and ejecting anywhere about 60-70% of the end diastolic volume. So the volume of blood that's within that left ventricle immediately before the heart beats, 70% of that is being ejected with each contraction. If we contrast that with the image towards the right of your screen, this is a failing heart, and you can see that these walls are, whilst the heart is going sort of relatively quickly, these walls aren't really moving towards one another. There's not a great deal of movement of the annulus towards the apex, and very little of the end diastolic volume, so the blood within the left ventricle at the end of diastole, is being ejected with each contraction. Now, there are a number of mechanisms by which your body responds to a low blood pressure, no tissue perfusion, and we're going to think about the baroreceptor reflex and the renin-angiotensin-aldosterone system. And both of these compensatory mechanisms use an increase in systemic vascular resistance, by which I mean the smooth muscle within the arterioles and the other blood vessels of the body contract and do what we call vasoconstriction, and this stops the blood from being sort of so spread out within the vessels of the body, and actually sort of squeezes that sort of blood supply back towards the vital organs, back towards the heart. And there are a number of mechanisms that the baroreceptor reflex and renin-angiotensin-aldosterone system use to do this. So there is sympathetic nervous stimulation of the vessels themselves by nerves which are sort of plugged into the vessels, if you like. There is circulating adrenaline and noradrenaline, which has been released from the adrenal gland, which act upon that smooth muscle to make it contract. And then there's another vasoconstrictor called angiotensin 2, which is released during the renin-angiotensin-aldosterone system, that also acts to constrict that vascular smooth muscle, and in doing so increase the blood pressure. Now, it also increases this thing called afterload. So afterload is a pressure which the left ventricle must overcome in order to eject blood through the aortic valve and out into the systemic circulation. Now, if you think of all those blood vessels, all the musculature within those blood vessels constricting, that's afterload is going to go up, and so this failing heart is going to have to work that bit harder to eject blood out through the aortic valve, because it's having to work against this greater afterload, that greater pressure. And actually, we're probably making the situation that bit worse by increasing the systemic vascular resistance. The next thing I want to consider is preload. So you recall there's a relationship between how full the left ventricle is at the end of diastole, so when it's been relaxed in between contractions, and when the fuller it is, the more stretched the sarcomere, which are the functional units of the myocytes, which are the heart and muscle cells. The fuller the left ventricle is, the more stretched those things are, the greater the force of contraction and the greater the stroke volume that you then get. And that's what we refer to as preload. Now, if you have a situation whereby your patient is hypovolemic, so they've lost fluid either from losing blood or from other bodily fluids, or they've had a really poor intake, if we were to give that person extra fluid, then we would increase the volume of fluid within the left ventricle, and in doing so we would be able to increase that force of contraction and stroke volume. And the body's sort of mechanisms for doing this are that increase in vasoconstriction that we were talking about just now, and so that's squeezing the blood away from the peripheries, increasing the venous return to the right side of the heart, and from there on the left ventricle, so that's increasing the preload, we're stretching that left ventricle, and also we're conserving fluid by reabsorbing sodium and therefore water from the kidney itself by the release of aldosterone, which is a hormone that's released during the renin-angiotensin aldosterone system. Now, if we are increasing blood flow back to the heart and filling up this LV further, if we've got this failing heart here, it already looks pretty full. The problem isn't that there isn't enough blood getting in there. The problem is that this heart is being overwhelmed, if anything, by the amount of fluid there is. So there's compensatory mechanisms to improve the blood pressure by improving the preload, actually putting more strain on the heart. And if we consider cardiogenic shock or that failing heart that we've just demonstrated there, the more fluid we're sort of pushing in, squeezing into that left ventricle, actually you reach a point where it no longer improves the force of contraction or the stroke volume. In fact, it has the opposite effect. And because the heart is so overstretched and is failing to cope with that fluid, we actually end up with less blood being ejected from that left ventricle because the muscle simply can't cope with what's happening. So again, we could refer to this as a maladaptive response. The final variable that we can consider is increasing the heart rate. So you'll recall from the response in the baroreceptor reflex, it sort of lessens the frequency of impulses along the vagus nerve. Now, the vagus nerve in this situation acts as a brake on the heart rate itself. So it acts upon the SA node and the conduction system through the heart, and the vagus nerve will slow everything down. And during the baroreceptor reflex, we reduce the frequency of vagal stimulation. So if you like, we're releasing the brake on the SA node and the conducting system in the heart, which consequently means the heart will go faster. And again, in the context of a heart that's sort of relatively strong, that increase in heart rate will lead to an increase in cardiac output and an increase in blood pressure. However, this heart's already going relatively quickly, and actually making that heart go faster will mean that there's less time for the ventricle to refill, which could argue might be a good or a bad thing in this situation, but also increasing the heart rate will increase the work rate of the myocardium, therefore increasing the demand for oxygen. And so if you've got this failing heart that is damage by infection, or more pertinently by an acute coronary syndrome where ischemia is the issue, then actually we're probably going to make that injury worse by increasing the heart rate. So we can see that our ordinarily very helpful compensatory mechanisms that would increase stroke volume, heart rate, and systemic vascular resistance actually could further injure that failing heart and not necessarily mean that there's an improvement in cardiac output or blood pressure. And we would refer to these things as a maladaptive response. So in summary, the renin-angiotensin-aldosterone system and baroreceptor reflex combine to maintain blood pressure in tissue perfusion ordinarily. However, in a failing, poorly contractile heart, the compensatory mechanisms may worsen failure. Vasoconstriction increases afterload. Increased preload may actually reduce stroke volume because the left ventricle is overwhelmed. And increased heart rate may worsen ischemia. Excuse me. Just dropped my nose. Apologise for that. Thank you very much for listening.